Well, good afternoon, everyone, and welcome. This is our Back to Basics webinar series. And for those of you that have joined us before, it is great to see you again. If this is your first session with us, we're glad to have you. This is actually our last session for Back to Basics. And we'll talk a little bit more about that as we get to the close of our session today. But just to introduce myself, I'm Andrea Boucher. I am a Quality Improvement Advisor at Superior Health Quality Alliance. I'll be the facilitator for today's session. And what we will be covering today is emerging trends in chronic disease management. And this is presented by our Superior Health Chronic Disease Management team. So you've got quite a few of us joining today to cover various topics here. We will be sharing the link to today's slides in the chat later on in the session. So you can grab that and access this information. But if you do have any questions throughout our session today, we do encourage you to pop any of those questions or comments into the chat box, and we will be able to address those as we move throughout our session today. But just to go over our objectives for today's session, we will be exploring emerging trends and the impact on the management of chronic disease, recognize the importance of interventions to manage patients with chronic diseases, and also to identify available chronic disease management resources and tools to implement within your healthcare setting. So without further ado, I will go ahead and turn it over to Carrie to kick us off.
All right, I'll have you advance to the next slide, Andrea. All right, I'm going to kick us off with diabetes. I wanted to share some updated information on diabetes. As we know, diabetes is an epidemic, and by improving or addressing diabetes, we can improve individual health outcomes, reduce healthcare costs, and enhance the overall public health. So early detection is crucial because diabetes can lead to chronic kidney disease, end-stage renal disease, and these are major burdens on the Medicare system. So between 2011, and I apologize, there's a typo on the slide, but between 2011 and 2020, the prevalence of diabetes among US adults aged 18 and older saw a significant increase. So currently where we stand, about 37.3 million individuals, representing about 11% of the US population, are affected by diabetes. And this condition is particularly concerning because it often coexists with other health complications or conditions, especially when they're not properly managed. So as we know, elevated blood sugar levels can severely impact our vascular system, and this leads to further health issues. So to further drill this down, of that big number, the 37.3 million, 28.7 million have been diagnosed with diabetes, but then there's another 8.5 million people who have it, but are unaware. So about 1 in 5 don't know it. Or to put it into a different perspective, like if you're in a room or you're in a restaurant and there's 42 people in that room, about 8 of them out of the 42 people would have diabetes, which is pretty significant when you look at it that way. Next slide. I wanted to focus a little bit too on prediabetes. So prediabetes, that encompasses individuals who have not been diagnosed or they may be unaware of their condition. And this affects about 96 million people in the United States. And that includes the 26.4 million adults age 65 and older. And that's very significant because for those age 65 and older, chronic diseases associated with diabetes further complicate their health. And when these numbers are combined, the escalation of the disease becomes evident. So as you can see, the financial burden of diabetes is substantial. So in 2022, the estimated cost of diagnosed diabetes was $412.9 billion, which is a number I can't even fathom. That includes $306.6 billion in direct medical expenses and $106.3 billion in lost productivity. So that means like individuals who are of a working age with diabetes, they often need to take more sick days to manage their condition and its complications, such as high or low blood glucose levels, leading to increasing costs. And this can lead to a reduction in overall work output and can also strain both the individual and their employer. Next slide. So to focus a little bit on individuals over the age of 65 and type 2 diabetes, managing type 2 diabetes in people over the age of 65 requires special considerations due to the unique challenges and health conditions that often accompany aging. And I just wanted to share some key points to keep in mind about those individuals. So older adults should have regular checkups or medical evaluations to monitor their overall health. And this includes blood sugar levels, blood pressure, and cholesterol. And also, it's important to screen for diabetes-related complications, such as cardiovascular disease, kidney disease, and vision problems. Along with that, treatment goals should be personalized based on the individual's goals, their health status, life expectancy, and the presence of other medical conditions. And with this older population, hypoglycemia can occur rapidly. Older adults are at a much higher risk for hypoglycemia, so it's crucial to avoid an overly aggressive blood sugar control regimen. With that, keeping it simple for medications can help improve adherence and also reduce the risk of medication errors. And it's also important for older adults to monitor those side effects. They may be more susceptible to side effects from diabetes medications, so regular monitoring is essential. As we all know, there's those lifestyle modifications. A healthy diet is very important. A balanced diet rich in whole grains, vegetables, lean proteins, and healthy fats can help manage blood sugar levels, in addition to physical activity. So encouraging regular physical activity, even if it's walking to the mailbox and back, or light exercise, can improve insulin sensitivity and overall health. It's also important to provide caregiver support, caregiver involvement, and education. So involving family members or caregivers in the patient treatment plan can provide additional support and ensure adherence to the treatment. And providing education about diabetes management, including recognizing symptoms of high and low blood sugar, is crucial for both patients and caregivers. And then of specific importance for our older individuals, really screening for cognitive impairment is important, as it can affect the ability to manage diabetes effectively. And it's also to be aware of mental health conditions like depression, anxiety. They're very common in older adults and can impact diabetes management. So overall, by taking a comprehensive and individualized approach, older adults with type 2 diabetes, our end goal is for them to be able to manage their condition effectively and maintain a good quality of life. So next slide. Our next topic is hypertension.
Thank you, Carrie. I will take it from here on hypertension. As you can see here on this first slide, we have the current blood pressure guidelines as recommended by the American Heart Association. And it's really important, actually, the biggest part about controlling hypertension is the diagnosis, of course, of hypertension. And the diagnosis, a big part of that is a proper proper technique for taking blood pressure. And as you'll see at the bottom of the slide here, I'm not going to go through the technique for taking blood pressure, but we do have a great video on the proper technique for taking blood pressure at the bottom of the slide, and it's also at the resources at the end of this presentation. So on the current guidelines listed here, we've got the normal and the elevated is 120 through 129 for systolic and still less than 80 for diastolic. When we get into hypertension stage 1, that's the 130 to 139 systolic with anywhere from 80 to 89 for the diastolic. And when we're at hypertension stage 1, as a healthcare professional, we really should start talking to your patient about lifestyle changes. You know, and a lot of those, I'll cover them on the next slide, but a lot of them Carrie is already covered for diabetes. You may consider for some patients who have heart disease or at risk for stroke or have diabetes or heart failure, those or kidney failure also. If they're in hypertension stage 1, you may also want to consider adding a medication for that. Hypertension stage 2 is 140 or higher for a systolic, and then 90 or higher for diastolic. And here we want to, again, have those lifestyle modifications, but you would want to prescribe medications for that. And we'll talk a little bit more on those in the upcoming slides. And then on the slide 2, you also can see that we have the hypertensive crisis listed here, and that's anything higher than 180 for a systolic and 120 for a diastolic. And the thing I want to mention for this, if you have like an SMB or self-measured blood pressure program happening, I mean, it's one thing if you take this and it's in the doctor's office or the hospital, or if you're in a long-term care facility, but if it's a patient is maybe part of an SMBP program, and they report this to you, you know, talk to them, you know, have them wait 5 minutes and take it again. And then of course, if it's still that high, they should be seeking medical attention. Next slide, please. So here we've, when we talked about hypertension stage 1, we talked about lifestyle modification, and actually for all stages of hypertension, you should be also talking about lifestyle modifications. But a lot of this, like I said, Carrie covered, it's the same that we would want to do for those with diabetes. So it's maintaining a healthy weight, a healthy diet, looking at their intake of sodium. We've seen a lot of studies that sodium intake, of course, really has an influence on hypertension. Looking at dietary potassium, that actually enhance or get more dietary potassium in their diets. Physical activity makes a big difference when it comes to hypertension. So just even like Carrie said, walking to the mailbox, you know, making those small changes can make a big difference. And then also moderation in alcohol consumption. Next slide, please. And for stage 2, and like we said, in some cases for stage 1, these are the first line blood pressure medications that are recommended. So looking at the, you can read them here too, but the thiazide type diuretics, calcium channel blockers, angiotensin converting enzyme inhibitors, and then the angiotensin receptor blockers. There are some cases for those with stage 2 hypertension, and it depends upon if they're, you know, they're above their target BP, you might want to look at the addition of 2 first-line agents. Also, there's single dose combination pills that may be of help for these patients and in their blood pressure control. So next slide, please. And here I'm just going to talk a little bit, next 2 slides. It's about looking at barriers and how identifying the barriers and addressing them for blood pressure control, first for the patient, and then in a clinical setting, some of those barriers. And so it's the first thing we have up here is social drivers of health. And so looking at a number of different things that could be affecting the blood pressure. So when we tell patients to get more exercise, we need to find out, can they even, you know, like if we tell them go walk to your mailbox, you know, maybe they live in a neighborhood where it's not safe to be out walking. So some of this, you know, if we're not seeing improvement in blood pressure for patients, I think taking a deep dive into those social drivers of health can be helpful. Also, maybe they don't have access to healthy foods. You know, we're telling them to, you know, eat healthy, and maybe, you know, they only have access to, you know, quick preparation meals, or maybe their lifestyle, you know, they have a hard time cooking, you know, and because of, I don't know what the reason could be, but maybe they don't have access to fresh food, I guess is what I'm trying to say. So, you know, if they're eating a lot of canned foods or frozen, some frozen, you know, prepared meals are highly processed. So those can be some things that might be affecting their ability to make those lifestyle modifications. I want to talk a little bit too about the suboptimal adherence to antihypertensive medication. This is another thing too, where you want to talk to your patients if you have put them on a blood pressure medication and you're not seeing that change. And I'm sorry if you've listened to me before and heard me give this example, but I feel like it is an example of, talking to your patients who maybe are on a blood pressure med and you're not seeing a difference, doing a little bit deeper dive sometimes. And I'm going to give the example of my father, who was on a blood pressure med. He was supposed to take it twice a day, and his blood pressure wasn't getting better. They're asking him why not, or are you taking the pills? And he's like, well, I only get the one taken. I don't get the second pill taken. So, instead of digging deeper, they were just like, oh, non-compliant. Well, I asked him, why aren't you taking the second pill? And he's like, well, I don't get up till 11 in the morning. It says I'm supposed to take it twice a day, 12 hours apart. I fall asleep watching TV at 11 o'clock at night. I don't wake up till 2. I figure it's too late to take the second pill. Nobody ever asked him why he wasn't taking the second pill. They just kind of wrote it off. So sometimes we need to do those deeper dives as to why people maybe aren't, like I said, why they don't have access to good food, or why they aren't exercising, or why they aren't taking their medication correctly. So it's a few extra questions, I get that, but just kind of looking deeper into what might be the barrier for those patients. Also looking at insurance coverage, prioritize maybe those single dose or low cost daily medications if possible, at least to start, those that might be covered by the insurance, instead of ones that maybe are not. Also, what are some patient reminders that you can do? Are there digital reminders, those kind of things, or that you can work with the patient on? And then too, if you're going to do a self-measured blood pressure program, making sure there's reimbursement for that, and making sure that you're using blood pressure devices that are actually validated. So I didn't cover everything here, kind of hit the high points, but if you want to go to the next slide. Just looking too at, again, barriers and addressing those barriers on the clinical side of it. There's a lot of different things out there. We know it seems like hypertension guidelines can be too complex, or that they're changing often, so there can be confusion there. So, what we really want to look at in those cases, I've got kind of the strategies below too, so I might be going back and forth between them here. But so looking at kind of that team-based care approach, and using that team-based care, adopting those standardized blood pressure measurement protocols so that everybody's kind of on that same page. We know that there's a lot of time, or a lot of competing priorities for your time. So that's kind of another thing that can hamper working with patients on their hypertension control. But again, team-based care might work here. Another thing that we see, I don't know how many of you are doing the self-measured blood pressure programs, or you might have a patient who's has their blood pressure cuff at home and brings in their blood pressure readings. So there's that belief sometimes that the out of office blood pressure measurements maybe aren't as accurate. So that it's just the ones in the office that are accurate. So looking at, again, if you are doing an SMBP program, or even the patient himself or him or herself has bought their own blood pressure cuff, making sure that it's, a validated blood pressure device, and so that you can have a little bit more confidence in what they're bringing in for numbers are accurate. Because a lot of times, what you're seeing in the office, there's either, there could be white coat syndrome where their blood pressure is higher than it maybe is in normal, or sometimes we see patients actually who their blood pressure is higher when they're not in the office, and we don't think they have high blood pressure because it's okay when they're in the office, but then yet when they're outside the office, it's high. So just kind of, if that's something to put in place, those self-measured blood pressure can be real helpful in diagnosing and treating blood pressure. And with that, I believe I'm turning it over to Rachel.
Thank you, Jerry. My name is Rachel Dibble here, and I will be talking about metabolic syndrome and obesity. And let's just start out with the definition. So metabolic syndrome defined. Metabolic syndrome is a serious health condition that puts people at higher risk of heart disease, diabetes, stroke, and diseases related to fatty buildup in arteries, or arteriosclerosis. Underlying causes of metabolic syndrome include overweight and obesity, insulin resistance, physical inactivity, genetic factors, and increasing age. So if we were just to stop at the definition and we think about what Carrie and Jerry have already talked about, sometimes this is the beginning of those conditions, diabetes, hypertension, for example. So metabolic syndrome is a cluster of conditions um, that create metabolic syndrome. One major one of them being is weight. And as we can see with weight, physical inactivity, etc., diabetes can come out of that. Hypertension can come out of that. So when we look at our patients, we really need to focus in on the condition of metabolic syndrome. Next slide, please. And so one of the things that is great about metabolic syndrome is that it's not hard to diagnose at all. And in that, it's basically looking at your patient. So what is the diagnostic criteria? Waist circumference for men, 40 inches or more, 35 inches or more in women. So we can tell that just with our naked eye of what our patient's habitus looks like. Triglycerides, this is on your lipid panel. So if they're up greater than 150, we know we have some cholesterol problems, which can be familial or it could be dietary. Reduced HDLs, which is high density lipoprotein cholesterol. So less than 40 in men and less than 50 in women. So these HDLs, as we know, these are your good cholesterols. You're healthy is how I remember it. HDL, healthy. Elevated fasting glucose of more than 100. So when you're looking at more than 100 and your diagnosis cutoff is 126 for diabetes, this person is edging up. This is a fasting glucose. So 100, we're even getting in pre-diabetes world. So again, that's why identifying metabolic syndrome early is very helpful in then mitigating hypertension, diabetes, or decreasing the risk rather. So here we are with blood pressure, values of 130 over 85 or higher. And the reason for that simply is because often with obesity, you have diabetes, then you have chronic kidney disease with your diabetes. And when you have chronic kidney disease, you're going to have hypertension. So you can see how it snowballs with really the beginning of the condition of metabolic syndrome. I have an apple in the right side of the slide. So when you see someone with an apple habitus, they are at high risk for cardiovascular events. So again, just looking at our patient for 10 seconds, we can size up pretty much all of their risks because of their habitus. And then we run the labs to see what's going on inside. Next slide, please. So why is obesity important related to metabolic syndrome? So this is a pretty I would say on the nose diagram, if you will. So if at the very top of it, which is what I was just explaining, so we're looking at all the visceral adiposity. So we're looking at just the habitus of the patient. And then in that, we go to the next stage. And these are all the issues that happen with your glucose, your insulin, related, again, go back up one to the habitus. Then what does all of that equal? What it equals is chronic inflammation, hormone activation, and insulin resistance. So right there, we know insulin resistance equals diabetes, which probably equals chronic kidney disease, which equals hypertension, just from the visceral adipose tissue on this patient, right? We go down one more, and then we're looking at metabolic syndrome. We've got our waist circumference greater than what it should be, our fasting glucose, and our blood pressure. So those are really the three diagnostic tools. Again, you can see it with the naked eye. That's why it is so important to start working with your patients from the beginning, opposed to when they start accumulating these chronic diseases. Next slide, please. So metabolic syndrome and emerging trends. So what can we do to enhance our outcomes? So initial labs on all of your physicals. particularly just your annuals, all the labs, you're looking, your CBC, your CMP, and your lipid panels. Evaluation of complications, asking your patients questions. This could be a sensitive topic because it's related to weight. So the ask, offer, ask motivational interviewing modality might be the best way to get people to open up so that at least you can understand where they're coming from. Patient education is key. I like visuals for patients to understand what weight can do and what weight eventually will do. Something maybe not as complicated as the slide I showed before, but something that is very specific of what just weight will do. Lifestyle modification. I know we hear the word ad nauseum, lifestyle. But again, with this ask, offer, ask, or really understanding your patient, the SDOH, what maybe they can't eat, like Jerry said, with healthy fruits and vegetables, etc., because of their income. Pharmacological management, again, there are many modalities now for weight, particularly the GLP-1s that we're hearing about all the time now, which is it is an old diabetes medication. So it's indicated for weight loss. And from all the literature, it is a safe modality. Then the surgical management, when it is to a point that the risks outweigh the benefits for the patient and their habitus. Next slide, please. So our takeaways here, consultations when appropriate. So what that means is if you see a new patient, they have a habitus that points to metabolic syndrome, you probably want to go ahead and potentially set them up with an RD, diabetes education nutritionist, particularly if they're pre-diabetic or diabetic. Endocrine sometimes has a place here as well. So in that, make sure you're consulting early, and that's the key. Sleep apnea is a very big deal for these patients, in particular because of the cardiovascular risk. What the literature is saying now is that sleep apnea is a component and can be a component for heart attack or myocardial infarction and stroke. A large majority of the patients who have metabolic syndrome have sleep apnea because of their habitus. Again, their neck is large and they can't get the air down, so the CPAP pushes it. That's what they have to wear. So this is really a big deal to understand if they have sleep apnea. And then again, a consult for a sleep specialist would be appropriate. Recognizing the development of metabolic syndrome, again, that's the first time you see that patient, it's recognizable. You're looking for that apple, you're looking for that the waist circumference, the blood pressure, and the glucose. IDT meetings, everyone should be involved in these IDT meetings insofar as your care planning meetings. And so getting a plan together with all of the providers, understanding the urgency at the beginning to start with behavior change, pharmaceuticals, potentially lifestyle modification, physical exercise, etc. Next slide, please. The key to managing metabolic syndrome is education, because often people think, our patients think, I'm just overweight, it doesn't really matter. But when you show them with a picture, again, the trajectory of this, it does catch their attention. The importance of weight loss and lifestyle change. Again, lifestyle change, what does that mean? What does that mean to your patient? Because they may have different resources, no resources, etc., that you would need to know about to support this patient in their journey of weight loss. The dietitian should educate the patient on the Mediterranean diet. We know that Mediterranean diet is the recommendation. I also like the DASH diet because of hypertension. And the medication compliance with whatever chronic diseases may have happened out of metabolic syndrome. So again, it's really, we got to move the body, move the body, move the body. It doesn't have to be a marathon. It could be gardening. That's moving your body, right? Burns calories. We really have to look for that cholesterol, watch that blood pressure and glucose, because that's where you get into your hypertension and your diabetes and your hyperlipidemia, strokes, MIs. All starts from here. Next slide, please.
All right. So
So
next,
I will. Oh,
sorry, I'll go ahead, Rachel. I'll move into tobacco cessation. Obviously, this fits in with all of the topics that have been covered so far. As we know, tobacco use can definitely exacerbate those chronic conditions and make it a little more difficult for patients to manage those conditions if they're using tobacco. So taking a look at tobacco use by the numbers, we have seen cigarette smoking decline in the US over the past 50 years. So taking a look back to 1965, about 42% of adults had smoked. And as of 2022, 12% said that they did. So we are definitely seeing progress in this area, but that still means that 29 million adults are smoking cigarettes. We know that cigarette smoking increases the risk of at least 12 cancers. So really, we need to think about what we can do about this. We can see that traditional ways to decrease tobacco do lead to positive health effects, and that's for most groups of people, but there are definitely certain vulnerable populations who have some fewer health benefits. We need to start implementing targeted cessation programs towards some of these more marginalized groups. Cigarette smoking is much more common among people who have less education or whose income puts them below the federal poverty level. We see that within certain ethnic or racial groups, in lesbian, gay, bisexual, and transgender communities, people who may have mental illness, who are in the military or reside in certain areas of the US. So in taking a look at what the American Cancer Society recommends for healthcare providers, payers, cancer organizations, and even state, local government agencies to really focus on new, different strategies that can target these groups of people specifically. One example is the FDA's This Free Life campaign, which is aimed at reducing tobacco use in the LGBTQ community. We also can see that if leaders put more effort into what we know works for reducing smoking and tobacco use, such as increasing taxes on cigarettes, we can see that we do see lower usage when implementing those kinds of activities. And really just ultimately, in addition, tobacco cessation services, making them more widely available can help to impact these numbers greatly as well. So when we look at the total cost of tobacco use, cigarette smoking is still, one of the leading causes of preventable disease and death in the US. Cigarette smoking kills more than 480,000 Americans each year, and the cost to the US is more than $600 billion. That was based off of 2018 data, and more than $240 billion in healthcare spending. We've also seen $372 billion in lost productivity. So a lot of impact on the cost to the US just based on the use of tobacco. We've also seen that for every $1 that a state invests in reducing tobacco use, on the flip side of that, tobacco companies are spending about $12 to promote the use of tobacco. So we really need to target interventions, like I had mentioned, in order to reduce them on a broader scale. Even just a 10% increase in the average price of a pack of cigarettes can reduce cigarette sales per person by an average of 7%. So to make a large scale impact, those kinds of interventions need to be implemented. But really, bringing it down to what you can do for patients, we know that quitting smoking can be extremely difficult. One of the main ingredients in cigarettes is nicotine. That is a very highly addictive substance. Researchers and other professionals are continuing to look at and creating new ways to help smokers quit. One of the top 2 emerging trends in smoking cessation that I want to make sure we mention today are the smartphone apps and also some new behavioral techniques. So with those smartphone apps, there are many different options available out there that are geared towards helping people quit smoking. Many of these apps are designed to help them quit by providing tips. They can track their habits and their use of tobacco. They can connect with other users on the platform and connect to support communities. So the effectiveness of those apps do vary, but they offer a lot of convenient and accessible ways for smokers to seek help and really use those that assistance outside of a clinical setting. Some new behavioral techniques and innovative methods that we see here are mindfulness and cognitive behavioral therapy. Those are being explored to help smokers quit by really addressing that psychological aspect of addiction. Cognitive behavioral therapy provides participants with better skills. It helps with coping mechanisms and helps to cope with those cravings and also those negative emotions that people might experience in order to maintain abstinence. And that's in comparison to other interventions that have been in place too. Also, technology-based interventions. So outside of the apps that I mentioned, there's other technology-based solutions, text messaging support, web-based interventions. Those are being utilized to help with smoking cessation as well. And also, lastly, is nicotine replacement therapies. So this type of therapy is really very helpful, especially when it's used in combination with the other strategies I mentioned, using that with behavioral therapy and with the support through those smartphone apps or other technologies, along with working with healthcare providers, can be really helpful in allowing a person to reach a quit status. And with that, I will go ahead and turn it over to Jerry to cover immunizations.
Thank you, Andrea. Next slide, please. So I just, when we're talking about the influenza vaccine this year, the biggest thing or change or new thing you're probably going to hear is that we're talking more about trivalent versus the quadrivalent vaccine. And this is because of the data that we've been collecting, especially since March of 2020, that really has seen the elimination of the Yamagata type B flu strain. So therefore, that is why they are doing the recommendation of the trivalent versus the quadrivalent flu vaccine. And this slide here just really illustrates what the composition of this season, the 2024-25 influenza vaccines will look like. Next slide, please. As far as the recommendations for influenza, we're not seeing a real big change in that. Again, APEC is recommending that all patients over the age of 6 months, unless they have a contraindication, should be getting the influenza vaccine. And then also anyone who is between the ages of 18 and 64 who has had a solid organ transplant especially should be getting that high dose trivalent influenza vaccine along with anybody over the age of 65. And I just wanted to touch on, the importance of getting this flu vaccine into our patients. From 2010 to 2023, we've seen almost 41 million illnesses caused by influenza and about 51,000 deaths. And this causes a great burden not only to the healthcare system, but also just to, the community and families. And so this is, for the most part, a preventable. So that's why I just wanted to, reiterate the importance of getting the flu vaccine to your patients. Next slide, please. Next, COVID vaccine. So APEC is, of course, recommending that you use the new 2024-25 COVID vaccine that should be available now. So let us know if you're having problems getting a hold of that vaccine. From what I'm understanding, it is available, so everybody should be able to be getting it. And I'm sorry, I'm just kind of hitting the highlights on some of these slides, but as we can see here, this is the makeup for the 2024-25 formulation for the COVID vaccine. FDA really has looked at the monovalent JN1 and with a preference to KP2 as part of the 2024-25 COVID vaccine. So I'm just going to go on to the next slide, talking about COVID vaccine implementation. And here too, we're seeing there's not a big change in the implementation as far as the providers. Moderna still is a frozen presentation. It's good until, if you keep it frozen, it's good until the expiration date. If you do pull it and put it in your fridge, you've got 30 days to use it. Noravax is stable with refrigerator storage from 2 to 8 degrees Celsius. Pfizer, this is the one it continues to be, especially, you know, for like clinic settings, because it's still that ultra cold storage that needs to be done for the Pfizer. So it can be a challenge for, you know, smaller organizations, those that don't have that set up for that ultra cold storage. And then again, once you pull it out to give the vaccination, you do just follow the instructions, but there is a expiration time on that from once you've removed it from the ultra cold storage. And then you can see at the bottom here, the preparation has not changed for these vaccinations regarding Moderna and Noravax. They don't require a dilution. Pfizer does require dilution for those between the ages of 6 months and 4 years. Next is pneumococcal vaccinations. Oops, one more slide. Okay. So for the pneumococcal vaccine, again, not seeing a great change in these, other than we do, as of June of 2024, there is the PCV 21 that's available. But otherwise, you know, we brought PCV 20 has been out there since last year. So again, recommendations if you have a patient who's over the age of 65, especially with those who have comorbidities, making sure that they're getting that vaccination between the ages of 19 and 64. So 65, everybody over 65 and those who have comorbidities between 19 and 64 should be getting the pneumococcal vaccination. And then also there's certain adults who maybe already had the PCV 13, but haven't gotten PCV 20. So looking at those patients too. And if you want to go to the next slide, Andrea, there's a great little app here that you can, it's a Pneumovax Advisor. We recommend that, you know, this is just something that you can use. It's from CDC. It really helps because as we just talked about, 3 different numbers already, PCV 13, PCV 20, PCV 21, which one do you use and when do you use it? So this is a great little app that can be really helpful for that. And then the last vaccination on the next slide that I'm going to talk about is RSV. APEC is recommending everybody over the age of 75 should be getting the RSV vaccination. And then for those who are between the ages of 60 and 74 that have an increased risk, and we see the increased risk listed here, things such as chronic kidney disease, chronic lung disease, diabetes, severe obesity, if they're immunocompromised, we recommend they get the RSV vaccine. And you can see here, there's 3 on the market at this current time, and those are listed on the first bullet point. And if we go to the next slide, covered a number of vaccines here. And so this slide is about co-administration. And I realize it's a little small, but the link is also included to that chart. And so this is something that is really important to look at co-administration. And again, you need to meet your patients where they are, but for patients who are coming into your office that you maybe only see once a year and you don't know if they're going to be coming back, co-administration is, you know, something to talk to them about. Now, if you're working in a long-term care setting, you know, where your residents, you can space out their vaccinations, is a different story. But for those, when you want to make sure that they're getting the vaccinations and you're maybe only going to see them that one time, co-administration is a viable thing to do. the vaccines that I've just discussed, they're all non-live, so they can be administered simultaneously, or you can spread them out, depending on, again, what the patient wants. You need to meet them where they are, talk to them about it, and the safety of co-administration, or if they want to space it out, but they know they'll come back in to see you, then that's fine too. So I am going to turn it over to Casey now for cardiac rehab.
Thank you, Jerry. So when we go ahead and look at cardiac rehab, we're going to look at the importance and some new strategies. If you want to go to the next slide, we're going to start off with a polling question. How often does your facility make referrals to cardiac rehabilitation? Never, some of the time, most of the time. But always. So if you want to go ahead and fill that out. So how often does your facility make referrals to cardiac rehabilitation? All right, looks like we're getting some good responses here. Great, Jerry, I think we can go ahead and move on. I see some of the time and most of the time and a few never. So I think we'll get some good takeaway from this presentation. All righty. So cardiac rehabilitation is a comprehensive secondary prevention program designed to improve cardiovascular health following cardiac-related events. So participation in cardiac rehab can reduce the risk of death from all causes, subsequent cardiovascular events, and hospital readmissions. The typical cardiac rehabilitation experience consists of 36 one-hour sessions of team-based supervised exercise training, which includes education and skills development for healthy living and counseling on stress and other psychosocial considerations. So individuals who attend 36 sessions have a 47% lower risk of death and a 31% lower risk of heart attack than those who attend only one session. So we can definitely see the importance of attending those sessions. Next slide, please. And on this slide, we'll see some of the key benefits of cardiac rehabilitation. So the better medication adherence, improved exercise performance, because they're actually being supervised and corrected when needed, improved quality of life, improved patient mood. The patient gets out and exercises. That's shown to improve patient mood and reduce readmissions to the hospital, and improved quality of care and quality metrics. Next slide, please. So referring patients to cardiac rehabilitation. So what can we do as an organization to improve cardiac rehabilitation referrals, enrollments, and participation? So we did just take a polling question and said, the results showed that many of us sometimes, never, or most of the time provide cardiac rehab referrals for patients that are eligible. So what can we do in our organizations? So first off, we need to identify if we have a process or establish a standardized cardiac rehabilitation referral process for your organization. So to do that, we want to standardize and automate internal and external referral processes to increase patient participation by enrolling them in outpatient cardiac rehab programs before hospital discharge. So best practice, we want to refer them before their discharge. And then we want to make sure that they're getting into cardiac rehab in an appropriate amount of time. So there's a really great toolkit out there by the American College of Cardiology that I would recommend you look at for those internal and external referral processes and how to increase participation with that. And also we should be integrating EHR opt-out order sets. So essentially they're taking the patient's diagnosis code and they're saying this patient would be eligible according to their diagnosis code. And it's going to pop up an automatic referral for an order set referral. So is your EHR doing that? Is it capable? Is it something we just need to turn on? That's something that we should be looking into. And then obviously discharge checklists. So again, for more information, the American Association for Cardiovascular and Pulmonary Rehabilitation Resources for Professionals has a lot of great videos and tip sheets and tools. So those are two resources that I would definitely recommend that you check out. Next slide, please. So the Million Hearts Initiative is a national initiative co-led by the CDC and CMS with a goal of preventing 1 million acute cardiovascular events in 5 years. So they've also worked with cardiac rehab professionals to set a national goal of 70% participation in cardiac rehab for eligible patients. So recommendations include expanding the uptake of alternative cardiac rehabilitation delivery models and reducing system and patient barriers to participation. These steps may improve the referral, enrollment, and participation in these programs. So some of those things that you want to think about is, what are some of the patient barriers to participation? Is it the transportation? Is it the hours? Do they not have family and friends to, take them to appointments? Can we have flexible hours? Can we provide them with the transportation brochure that we have on our website, or transportation in your area? Do you have those referral sources for those patients? Next slide, please. And then I want to talk a little bit about cardiac rehabilitation desert areas. So cardiac rehabilitation desert areas are areas with poor availability of cardiac rehab programs. And we have several within our states, desert areas. So statistically, 14% of adults live in counties with lack of cardiac rehab centers, and 74% of adults live in counties with less than one cardiac rehabilitation center per 100,000 adults. So that's a lot, right? We already know access to care is difficult. So looking at one cardiac rehab center for 100,000 adults, that's an access issue. So what are our next steps? The next steps to reach the Million Hearts goal of 70% cardiac rehab participation may require the expanded delivery of traditional or in-person cardiac rehab sessions, while also increasing the uptake of hybrid cardiac rehab programs that deliver cardiac rehab sessions in person and virtually using remote communication. So that's still having those hybrid programs, is still having those patients come into that brick and mortar, and maybe they do that once a week, or whatever they're able to do. And then the other sessions is a hybrid program where they still have a support person, they still have somebody working with them virtually, but they're at home doing those exercise programs. So that's something to think about as well. And then I'll turn it over to Andrea.
Thanks, Casey, and thanks to everyone who presented for us today. At this time, we can open it up for any questions that you might have. If you do have a question, you can feel free to either type it into the chat or you can unmute and answer. But I did just want to point out a comment from Terry in relation to cardiac rehab, because I think this is definitely really relevant. On a barrier for patients who are still working, the times and the frequency are prohibitive. They've already taken or used their PTO and can't take any more time off work to go to appointments during work hours. So thank you for sharing that personal experience, Terry. I'm sure that's definitely a common barrier, with many of those hours being during a typical work day. That can definitely be a barrier for a patient. So thank you for sharing that. All right, and I'll just pause if there are any questions. Like I said, you can put it in chat or you can unmute and ask a question. Not hearing or seeing any. If you think of any in the last few minutes that we have, feel free to pop it in chat, but we'll go over some next steps here with the remaining time that we have left today. A couple of resources we wanted to point out to you. We have revamped our Superior Health Quality Alliance website, and Carrie has placed the link for that in the chat. We do have a new resource library that is available for you. If you want to search chronic disease related information, you're able to search by that and filter out those resources. So we encourage you to check out our new website and access those resources that we have on the library for you. The next couple of slides we have here are resources in relation to all of the topics that we have touched on today. So if you are interested in checking out any of this information, we do have the slides available for you, so you can access. We've got 2 pages of resources for you. So a lot of great, again, this was all covered throughout the session today. So feel free to check out any of those resources at your convenience. But a couple more resources that are coming out very soon. We are going to have new tobacco cessation on demand learning series. This is called our Quitting Quickenar series, and it's really helpful to guide patients or residents, whatever type of person you might work with, in becoming smoke-free. So they are broken down into really small bite-sized learning modules on various topics. Each lesson should take you about 5 to 8 minutes. And there's quick knowledge checks at the end of these. So these are coming out soon. We will be sending out more information with the links on how to access this within the coming weeks. So feel free to check out your email and check those out when we have those available. And before we let you go today, we do want to launch our polling questions. Our first question is, I learned something useful in this session. So if you could mark yes or no, we would love to hear a response from you on that. So I'll give it just a moment for you to click a answer on that. All right, and all yeses so far. That's great to hear that this information was useful. And we'll go into our second polling question, which is overall, how satisfied were you with the information that was provided during today's webinar? So either very satisfied, satisfied, partly satisfied, or not satisfied. So again, if you could take a moment and fill out the poll that has popped up on your screen, we really appreciate that. And we do have an evaluation that's really brief. If you can take a moment to fill that out as well. We have provided the link to you in our chat. So if you could take a moment and fill out our evaluation on today's session, we would love to hear from you on that as well. And the link to today's slides are also available in the chat. And lastly, just wanted to mention, as I mentioned at the beginning of our session today, this is our last Back to Basics webinar. The Superior Health QIO program is moving into a transition period. So first off, we want to thank you all for all of your hard work to advance the health and the healthcare of your patients and communities. Since 2019, this has been a very quick 5 years, it seems like, but we appreciate all of the hard work that you have done. Our current 5-year cycle is coming to an end on November 7th, and we will have some new quality and safety goals, which will be announced in early 2025. So we do hope that we will continue to work with you and have that privilege in working with you again and being your quality improvement organization. But you can read more about all of the wonderful accomplishments that Superior Health has done with you and with other organizations since 2019 in our final report, which is linked on this slide. So if you have a moment, we would love for you to check out all of the wonderful things that have been accomplished in the past 5 years. But with that, I think we will go ahead and close out for today, since we're right about 1 minute from the top of the hour. Thank you so much for joining us today and for all of our Back to Basics sessions. We really appreciate your time and commitment to us. And again, thank you so much for all of your hard work. And we hope to see you again in our contract moving forward in the future. So thank you everyone for joining us today. Have a great rest of your day.